Hello, this is Wendy Wood, PT, DPT, going to be recording the second part of orthopedic conditions in the older adult. So, first of all, talking about Paget's disease. In a strange way, this is kind of like the opposite of osteoporosis, although it does result in malformation and actually the bone ultimately being weaker, even though in this case the bony formation overtakes the bony resorption. So you get overall increased osteoblastic activity, and you have this softening phase followed by a hardening phase. So there are three phases: osteoclastic, osteoblastic, and sclerotic. So in the initial phase, which would be the osteoclastic phase, this is a softening or reabsorptive phase, and there's characteristic deformities, typically a prominent forehead. So this individual is pretty advanced in that. Lower extremity bowing, kyphosis in the T-spine, and flattening of the L-spine, loss of the lumbar lordosis, and sometimes that posterior prominence of the vertebra. So, but in the very early stages of this, it may be somewhat asymptomatic. In the osteoblastic phase, the trabecular and cortical bone are thickened and there becomes more of an irregular bony alignment. So the bone is eroded, enlarged, and it's ultimately weakened. Malalignment is a big problem here. So in the osteoblastic and sclerotic phase, there's increased postural deformities, kyphosis, and the bowing of the legs. Oftentimes there's a waddling gait, increased fatigue, bone pain, and stress fractures. Some of the signs, symptoms, initially, like I said, little or no symptoms. Then there's a slow progression of disease. There may be elevated serum alkaline phosphate, and later more of a deep aching bone pain. Stress fractures can occur, and these skull deformities that could eventually be so severe they're causing headaches, tinnitus, vertigo, and hearing loss. And fatigue and lightheadedness, stiffness. Lastly, there are oftentimes cardiovascular problems associated with Paget's disease, and it's the most common cause of death. With osteoarthritis, that is one of the most prevalent joint pathologies found in about 50% of those 65 to 75 years old, in 70% of those over 75 years old. Primary cause is unknown, or I should say the cause of primary osteoarthritis. When someone has injuries and trauma and they get secondary, then it's more obvious. It occurs in specific joints, typically carpometacarpal, hips, and the knees. So interventions, and this is meant to be kind of a discussion slide, so just take a moment, think of those typical interventions that you're going to do. Of course, that would be pain management, and maybe the phases where the person has pain. We could teach them about ice and heat application, stretching, strengthening, and of course, strengthening of isolated types of muscles will provide more stability. And as we know, a lot of these individuals have gone kind of in a downward spiral. They've gotten severe osteoarthritis, and they begin just doing less, walking less, and they get weakness, secondary weakness. So we can work on how we might take them kind of out of that spiral and get them towards improved function and overall strengthening, but protecting their joints. Medical interventions And again, this is meant to be a discussion slide, so just kind of think for a moment. I think you're all familiar with this. Typically, the doctors are going to prescribe medications. It may be NSAIDs. It might be heavier medications, possibly even opiates if the pain is severe. And then other medical interventions that may be performed. Sometimes people have injections, synthetic type joint fluid, or maybe cortisone. And then eventually, maybe there's going to be so much wear and tear that the person needs a replacement of the joint. Rheumatoid arthritis is the second most common orthopedic condition in the older adults. And of course, we know this is different than osteoarthritis because it's more of a systemic inflammatory autoimmune disease. And the joints affected, small joints of the hands and feet, ankles, hips, shoulders, elbows, wrist, and the cervical spine, which is very important. A lot of times deformities are seen in the fingers due to the effects of tendon. There may be chronic inflammation of synovium and periarticular cartilage. Diagnostic test with rheumatoid arthritis, the red blood cell count may be decreased. The ESR, the erythrocyte sedimentation rate, that particular test may show an increase, and there may be a positive rheumatoid factor. Some of the treatment guidelines, again, take a moment and think about some of the things that you do for your rheumatoid arthritis patients and kind of what's important. Well, naturally, it's important if they're in an acute inflammatory phase. And in that phase, what might we do? Probably things for joint protection, right? We might look at splinting. We might look at things to relieve pain, splinting being one of them. Splinting, of course, is going to help with joint protection. And then modalities, ice, and heat. Of course, in terms of modalities, we may want to be careful that we're not increasing any inflammatory process. Okay, I should say now, let's go back to the RA. In the non-acute phase, in the subacute or the chronic phase, then that's where we may want to begin strengthening them. We might not push them as much as we push our osteoarthritis patients. With lumbar stenosis, and I think most of you know this, these patients were working on flexion, not extension, because that can exacerbate the problem. And in terms of osteoporosis, we're typically working on extension, right? Avoiding flexion with osteoporosis. So we want to avoid crunches and that kind of thing. Common orthopedic problems in osteoarthritis by joint. So let's look at joint problems. In the shoulder, osteoarthritis is actually pretty rare. It's more common to see bursitis, rotator cuff tears, adhesive capsulitis, or humeral fractures from falls, elbow, radial fractures, and that would be a fall, wrist, Colles fracture from a fall. In the hand, RA, like I mentioned, causes a lot of deformities. In osteoarthritis, we may see some enlarging of the joint. Dupuytren's contracture, that's something that could occur in RA. With the hip, osteoarthritis is common. Hip fracture, of course, in terms of osteoporosis. And then osteoarthritis in the knee. So in terms of subjective assessments, there are a lot of them, and subjective assessments are very important. Upper extremity, there's the DASH, disorders of the arm, shoulder, and hand. In the lower extremity, the lower extremity functional scale. With the spine, we have the Oswestry, which is more lumbar, but maybe it could be used in total back, and then the Neck Disability Index. And of course, there's many others. Functional performance scales, many different scales. And again, this was meant to be kind of a discussion point here. So kind of think about some of those measures that you might do. Manual muscle tests. We could do 5 times sit to stand, a 30-second sit to stand. Of course, you can look at functional mobility, even things like the FIM. And the timed up and go, although we think of that more in terms of balance, it's also a general functional measure. Okay, so that gives you an idea of some of the orthopedic problems that the older adults deal with. In terms of strengthening, again, I think, on one hand, we've talked a lot about frailty, but realize you can push these older adults more. We might be, I mentioned frailty because we do see those frail older adults, but we have many older adults that are doing very well. And I think we're not really challenging them enough. So, well, that concludes this lecture. Thank you.